everyone will take their seats. We're going to start on time because we have a packed agenda, as always. So hard to get 20 years into one day. So we have been ambitious, but it means we are going to be, Nadine is going to help us keep time. So I'm just warning all of our speakers, we are going to be ruthless in terms of cutting you off. There's a trapdoor here that'll open if you go over time. So just a warning. And I have to say that to myself as well. So I'm going to be careful about my time. So hi everyone. My name is Linda-Gail Bekker. I am the CEO of the Desmond Tutu Health Foundation, Director of the Desmond Tutu HIV Center, and it is my great pleasure to really warmly welcome all of you. Some of you are part of the organization in terms of staff and research, but many of you are also friends and collaborators. I see even some funders in the audience today. So it's just wonderful to have all of you here. I know that people have it's midweek and it's busy. People are also going to step in and step out. And we are absolutely fine with that. We understand that whatever time we can have of people will be wonderful. It is being recorded, so we are preserving this for posterity. So for those who maybe really wish they had got something but they couldn't stay, we will make this available after the event. But it is terrific, and I want to thank all the speakers who were volunteered. Very few actually got to volunteer, but wonderfully nobody turned us down. So thank you for that. And really, we really appreciate that people have put time and thought into the little short snippets they're going to be doing today. So it really is a journey. And thank you to Nadine, the broader team. First of all, let me start there to thank everyone for putting this together. It's always good. Thank you to Professor Fegan and the Neuroscience Institute for allowing us to have this venue. It's a beautiful venue. And I have some housekeeping stuff before I forget. So the housekeeping is, if you have received a parking ticket, we will reimburse that for you. So please find Tammy or Angela, Tammy at the back, Angela outside, to sign your little parking ticket, and you won't have to pay. We will pick that up. So that's the first thing. Secondly, the loos are proving to be a bit of a conundrum. So they are, when you go out, they're just before the exit sign. They're not actually labeled. But those are the loos. When you go in, please push the bolt, because apparently if you don't, people will just walk in. And that can be traumatic for some, it seems. So very good that we know that. If anything else comes to your attention and is concerning, please raise it with us, and we'll, during the course of the day, try and fix it. There is coffee to be purchased, but otherwise DTHC and F are also catering, so please, we'll announce those as that unfolds. There are tea breaks as per the agenda, lunch break, and then a tea break in the afternoon before our keynote speaker comes late in the afternoon. So my task then is to take us through the 20 years and more, because we actually have been around for longer than 20 years. But this is not a Festschrift in terms of, retirement. I really do want to say we are looking back at what we've achieved, but there is a real sense of excitement about what is coming in the future. And some of what you'll hear, for example, in the keynote this afternoon, is really about the work in the future and what is coming. But I've asked everyone also to reflect not only on looking back, but maybe also thinking in their various sections what is coming in the future. I thought I would just, not everybody may know how we roll, This is our vision, our mission, and our strategy, and maybe I'll hone in on that, is to impact lives, communities, policies, and practices through research, innovation, service, and evidence-based advocacy. And those are our values, as you see, and we really uphold those. We feel very strongly about our 6 values, and that is, as I say, near and dear to the heart. People don't always understand how these 2 organizations function together. They are joined at the hip. The DTHC is placed within the Department of Medicine, hosted by the Institute of Infectious Diseases and Molecular Medicine. I want to say hi to Val, our Director Emerita from the IDM, and we hope Digby might pop in. We are, our DTHC half is hosted in the IDM. We're part of the Department of Medicine, and we are, in the University of Cape Town. And as I say, joined at the hip is the Desmond Tutu Health Foundation, which is an independent, not-for-profit research organization with its own independent funding. But these 2 organizations really work very closely together. And we use the concept interchangeably because at the end of the day, we all have a similar goal and similar work to achieve. So these are our strategic objectives, really health-related research, and this includes basic, operational, clinical trial, and health service research. And as I say, to impact health policy and lives, individual lives. We do provide health service as part of the research we do. We really care about community engagement, and I hope that comes through. And I'll just say that a few months ago we had the flip side of this, where we went into the community and spoke about the science we do in communities. And that was a wonderful event that really mirrors this work that we'll be sharing today. And of course, we do care about developing capacity and mobilizing communities. So this is just the visualization of what we really want you to understand. And today we're talking about the research we do, because research underpins everything that we do, with the hope of having an impact on policy through publications, through public information, and through dissemination of the lessons we learn through the work. We do a variety of research, and again, I think you'll get a taste of this today, everything from large-scale implementation through clinical trials to, BL3 level research in the laboratory. Here are the sites where we function, largely in the Western Cape, but now very proudly with a site in the Eastern Cape as well. And those of you who are here and from the sites, I just want to give a shout out that we are here at kind of headquarters, if you like, but the work is happening in communities in the Western and Eastern Cape, and those are all the various sites. So again, thanks to Nadine for describing the journey, and this is small, but maybe during the day you can come through, but it's the roadmap for what we're going to do today, which is really work through the eras, and we start all the way back in the time of despair when this epidemic began to unfold. We were based at that point at the Somerset Hospital. It's pre-Desmond Tutu, so it really is before the 2004. And again, there are key people. And here I want to call out Liz Fielder, Felicity Cope, Joy for Life, key people that made such a difference, not necessarily in terms of treatment, because we didn't have treatment, or really very good prevention for HIV in those days. We had to make the passage into the next phase for young people who were dying of AIDS as comfortable as possible, and that was the work we did. So there was the CTAC cohort, but from there, and Val and I were just talking about this sort of amazing breakthrough of antiretrovirals. the first antiretrovirals coming through, and you'll hear from Catherine the work around adherence. And then fast forward to 2004, where we were invited from Somerset back into the fold, as it were, into the newly built Institute of Infectious Disease and Molecular Medicine. And that wonderful day in August of 2004, when the Archbishop Emeritus Tutu said, yes, we should be called the Desmond Tutu HIV Centre, and at that time, HIV Foundation. We subsequently changed our names to Health Foundation, moving with the times a few years ago. But we proudly bear the name of this wonderful, wonderful patron whose values really guide what we do every single day. And the rainbow in our logo is directly as a result of the Archbishop's influence around, as you know, all people count, regardless. And health is a basic human right for every single individual, not only in South Africa, but around the world. And then we'll move into the era where TB played such a critical role. And here again, I want to sort of focus in on people who we've loved and we've lost. Here's the late Steve Lawn, but also just, you know, the Hannon Crusade Centre in Gugulethu, the wonderful Sizophila team, Flora representing them, and we'll be speaking a little bit about them earlier. We've lost some of those wonderful people who really helped us formulate our ideas around differentiated service delivery, putting people in the middle of our care and understanding that it's for people that we provide the health services and the health service research that makes their lives better. And here is Sizophila project. I want to remember Lulu Mtwisha. We would have loved to have had her here today. We're going to send her definitely the YouTube afterwards. But Lulu, and of course her daughter Linda, now such a prominent person at the University of Cape Town. But Lulu really played such an important role. And of course, Sizophila counselors, the calendar girls, there they are, Flora, you were December calendar girl. And, you know, just terrific memories. I just want to say to people, this picture here was, I'm sorry, I'm going to name drop all the way through this, but this was, and you will remind me, the photographer, what is her name again now? Vogue. Annie Leibovitz came and photographed Sizophila in Gugulethu. So this is an Annie Leibovitz photograph. We all stood there while these fans were blowing at us, and everybody was amazed. But anyway, there you are. HIV prevention, of course, was a new era and such an important era. Here is Emma von Leni being built in the heart of Crossroads, and you'll hear the work that goes on. And thanks again to Steve and Lulu and the team for being here. Specialized groupings, also very important for us to think within the Desmond Tutu HIV Centre is our clinical trials unit. So you'll hear the important work that has gone on there, and this allows collaboration. So here we collaborate with UCTLI and with SATV, and this now we will be moving into our fourth iteration of being the clinical trials unit. That'll be, you know, more than 21 years of having a relationship with the Division of AIDS and doing the work for vaccines, for prevention, for treatment, etc. And yep, more pictures of Emma. The notion of being in the community and doing our research in the heart of the community, science and community, so important. Community engagement, I just hope that will really resonate with all of you throughout today, how important that has been for us. Community dissemination of our data and involvement and learning from community. I think this is the other thing you will hear today, is that the best science we've had is when we've put our ear to the community and we've asked them what their solutions are. This has led, as I say, to differentiated service delivery and our passion for key populations or other populations here, sexual minority and other key populations, LGBTQ health division, really the most colorful division of our organization, and our passion for adolescents and adolescent health. So the Youth Centre being the first iteration of that, terrific work we've done. And in that campus now, the innovation coming through, sorry that got cut off, but the innovation coming through in terms of the aerobiology work, and I whet your appetite to say you'll be hearing the details of that at the keynote later today. And now broadening beyond HIV, TB, and communicable disease into non-communicable disease. So the new frontier of asking what else is so important, particularly around adolescents. And so now, excitingly, starting to say, what about the health park, and how can we impact adolescents to have, healthier adults in the future. So here's the name dropping. We've had wonderful, wonderful opportunities to rub shoulders with all kinds of exciting and interesting people over the 20 years. And, most precious, of course, that man in the pink robe who we miss every single day. Here's a few other celebs that we've enjoyed seeing. But here I'm going to end. And just listen to this, please.
In the late 90s, the work had begun, putting back a living care at everyone. From UC halls to the fields beyond, we stood for change, helping lives live on. With Desmond Tutu's name held high in 2004, our mission reached the sky, building a legacy, laying the ground, a place of hope where answers are found. Expanding care, our studies aligned, mobile clinics reaching all in time. Insufficient and LGBT+, health for all, it's always been us. See up the screen for STIs, HIV testing, family planning, no lies. Adolescent care at the center's heart, free for all, doing our part. MMLCK, 52 and more, GROP, PNHQ at the core. With each site growing, expanding the scene. Eastern Cape joins the team so key. From full prep to long-acting care, we're keeping adolescents everywhere aware. Trials and signs every turn, helping the youth as they grow and learn. When COVID struck, Sizophila led the way. Vaccinating workers saving the day. Fetal health part, the vision's clear. NCD's now part of the work we hold dear. At Marcy, family planning's free. STI and HIV testing build a community. From Eastern Cape to sites in town, long-acting care is gaining ground. 20 years of hope, standing strong and true. With Tutu's light, we guide the way through. From early days to breakthroughs anew. Innovation, compassion, for me and for you.
So I want to say the brilliant architect there is Years Linda-Gail. Well done, Nadine. And with ample help from AI, it turns out. But I proudly, say that is going to be our anthem for the next 20 years. So well done and really brilliant. And now, without further ado, I launch the program open, and we're going to start with one of our oldest, but no, let me put that differently. Our longest-serving member of the organization, Catherine Orrell. Thanks, Catherine.
Do I have to close this? Oh, do I just move on? Oh, I've now done something, haven't I? There we go. All right. So I'm doing the very early days because I have been here a long time.
Into that thing.
Okay. I'm doing the very early days because I have been here a long time and I am definitely getting older. And so my part of this is to talk about the piece of time before we really had broad access to treatment. And for those of you who are there at the time, and I know some of you are here in this audience, our HIV epidemic was ignored for many years. There was a lot going on politically between 94 and 99 as our epidemic grew, and I don't think HIV featured in very many people's agendas at the time. And so unfortunately, it was allowed to grow into a very large epidemic. We were plagued by political interference. We didn't have treatment for years after the developed world had treatment, maybe 8, 9, 10 years before we could actually access treatment. And in that time, a bunch of us worked in infectious diseases clinics and HIV clinics and saw patients who died. And so basically all the people that I looked after between 1996 and 2002 passed away from HIV. I remember having to tell people to disclose their status because she had microsporidium disease, the CD4 was 27, she's got 2 young kids at home, and not told anyone. So I still get tearful about this because we have come a very long way. And my initial work here and in clinical trials was to gain treatment access. And Flora speaks to that because I met her in 2000 when she also was fairly unwell. And we got her access, well, she got herself access through Liz Fielder and the Imprenavir study, which happened in 2000. And of pharma companies, I have to say that one has stuck with us all the way through. And GSKV still have been supplying treatment for that cohort of women, mostly women, who got onto that study all those years ago. I have to remember that at that stage when we did do treatment trials, we were giving people lots. They had 8 tablets in the morning and 8 tablets at night, and we were still very grateful that the 3rd middle daily dose had actually fallen away. And so we've come a very long way in terms of treatment since then. So since not having access, and if we did have access, it being for 30 people and giving them handfuls of tablets, we are down to 1 tablet a day for the majority of people, for first line and second line. So things have really improved. But I think part of our growth as an organization has come from the sense of injustice, and that it's felt an important thing for us to fight for people's rights and to be part of the community of people fighting to make sure that treatment has been appropriately delivered to everybody over time. And just some of these cartoons that stick with me. You remember our various unfortunate health ministers, and we went through a whole period of AIDS denialism, which I feel that we are still combating the side effect, the piece that ARVs call side effects, lipodystrophy and things like that. Those still come to the fore. We still see people who don't want to start treatment because they're worried about changes in body shape and things like that. So the harm that was caused by those rumors 20 years ago is still being undone as we go today. The costs of medicines were prohibitive. You can see that, like, we're all like the third world there at the bottom while we're having things with medication withheld for us. People were dying for the sake of 700 Rand a month. The BMS eventually lowered the price of 2 very horrible drugs, DDI and D4T, and we managed to get those drugs as a pair, and people could buy them for 280 Rand, which was within the cost of a disability grant at the time. And some people started on those medications because that was the only thing that was available to them, and ended up with horrible peripheral neuropathy, but were still alive. And so we have come, as I say, a very long way since then, but we've had a run of stuff. All right, so my sort of real sense of injustice came from this man, Andrew Natsios, and if I ever meet him one day, I should actually thank him for my whole adherence career, because he essentially said, he was the head of the US Agency for International Development, and he said, Africans do not know what Western time is, and when it comes to taking medications, they're never going to manage to take medications twice a day on time. And that literally infuriated me, and I did my first adherence study based on clinical trials run in the then Somerset Hospital Trials Unit, and showed that Africans can indeed tell the time, and they can take medications on time, and in fact did better in a lot of ways than in the early days than European and American cohorts. So we did eventually get ART access. There was a lot of activism to get there. Linda-Gail got 150 treatment doses from Hannon Crusade at the very beginning, and undaunted, we went ahead with treating 150 people with only 1 year of medication. Now, a lot of people would take that as like, oh, well, what are we going to do afterwards? But you've got to start, and you've got to get going. And by the time we got to the end of that 150, we were at 350. And then Eric Gooseby came along and donated us some more drug. And eventually, we hit 2004. And the Global Fund actually donated drug. And we managed to keep a lot of people who would have passed away alive with that process. And at that stage, we were giving D4T, 3TC, and nevirapine or efavirenz, still twice a day. And again, that has simplified over time. So eventually, even though we've always been a few years behind the rest of the world, we have actually managed to get to the point where we have access to everybody for ARVs. And we have actually got it to the point where it's 1 tablet a day. And I have to say, the last few weeks, I've been moaning about the fact that we don't have injectables for treatment, that it's available for PrEP, and that's where we're going next, long-acting formulations. But I was in a meeting yesterday with a bunch of pediatricians, and you realize that they are still striving for 1 tablet a day. Kids have been long left behind in this drug development process, and they're still taking horrendous syrups. You know, they're like all excited by the dolutegravir dispersible tablet because really they have had nothing. So it was a good perspective for me to remember that sitting here as a treatment person moaning about 1 tablet a day when PrEP has 2 forms of injections coming up is actually still part of a spectrum. And there's a lot of work still to be done in the pediatric, adolescent, young people's population. And then just to show you my last thing, my last slide, or next to last slide, is that we did actually do better at the beginning. As the Guguletu cohort expanded, we managed to outdo Americans in following and being adherent to ARVs. And an initial meta-analysis showed that in Africa, we were doing a lot better than everybody else. That hasn't, unfortunately, always remained the same. And maybe fortunately for me, because I've had a whole career looking at adherence and doing adherence studies over time. But we did, as the sort of rollout and expansion of ARVs grew, so we actually changed the curve. So we can see from here, if there's a pointer, there we go, how in the early years, the 1990s to 2000, when we had no treatment, how people died, how the life expectancy of people dropped markedly over the years. And with the advent of broad spectrum ART, even with all the difficulties we have with our programs, all the difficulties with delivery, we reversed that drop in lifespan. And so the rollout of ART has been an undoubted success, and we now live in an era of living with HIV as a chronic disease. We now live in an era where we're fortunate enough to be able to look at HIV and aging. We're able to look at HIV and weight gain rather than weight loss, and we're able to look at chronic diseases that come with time, and blood pressure and diabetes. Now, I mean, for me, 20 years ago, if any one of my patients gained weight, I'd have been delighted, because we went through a phase where everybody lost weight and died, and now we have really come a long way. And that's all of us. I know a lot of our City of Cape Town and province partners are here. We've all worked hard together to make this happen, and I think we should give ourselves a bit of a pat on the shoulder for the South African ARV program in general. Thank you. On time.
I'm going to jump up and down just to make sure that we bring the next person along, and that is going to be Keren. So over to you, just press the forward.
Okay. So my job today is to talk about some of the, my job today, right, there we go, okay, is to talk about some of the TB work we've done over the years. And I'm not going to belabor this point, but I think we know that while South Africa has made gains towards the TB strategy milestones of 2025, the WHO estimates that every 2 minutes, someone in South Africa still develops TB. And as one of the WHO top 20 high-burden TB countries, and with 8 million people infected with HIV, it is not surprising that the Desmond Tutu Foundation has made the study of TB and HIV co-epidemics one of our priorities to try and help find solutions for South Africa. This is an early paper of ours from the early 2000s, before antiretrovirals were available in our communities. We looked at the interaction between the two epidemics in the local community that had a well-run TB DOTS program. And we showed that the increases in HIV infection, as the prevalence of HIV infections increased, so the associated population TB rates increased as well. And even as the HIV epidemic began to stabilize, we could see ongoing amplification of the TB epidemic for several years. And we also noted that the epidemiology of population TB was shifting, with age-specific changes. With the increase in TB in HIV-positive patients, we saw a shift to much younger members in our community starting to bear the brunt of the TB burden. So when we think about the colliding epidemics, we've done a lot of work looking at the impact on the individuals, and much of this came out of the programs that Catherine talked about, the early antiretroviral treatment programs. And Professor Wood, this was one of the very first papers from a treatment cohort in South Africa, where Prof. Wood reported that treatment with antiretrovirals significantly reduced the incidence of TB among our HIV-positive patients, and that a protective effect of ART was greatest in those patients with advanced immune suppression. Then came the era of the Gugulethu cohort, and Steve Lawn and Linda-Gail and Robin Wood produced a substantive amount of work looking at the challenges of TB in treatment cohorts, including looking at the long-term impact of ART on the incidence of TB in HIV-positive patients, showing benefit for years to come on ARVs, but also describing the ongoing risk factors for TB in these patients. And to give you a sense of some of the work that came out of this cohort, we reported on the importance of ART in reducing TB mortality over time. We looked at the role of ART in restoring immune responses to TB and associated issues of iris in treating patients with co-infections, and perhaps really significantly contributing to the critical discussion about when to start ART in patients receiving TB treatment. This team showed that a large majority of incident TB occurring in the first year of TB treatment could actually be detected as prevalent disease at baseline. And so if we did a pre-screen for TB before initiating ART, we could reduce the complications of treatment in the first few months. And screening, anyone who's worked in TB knows that screening and diagnosis for TB is not without its complications. And this team tackled challenges looking at different screening options, assessing the role and value of different diagnostic tools, including induced sputum and gene expert and urinary lamb. And I just want to say that a lot of the information, a lot of this knowledge and the practices that have arisen out of this early work, we take for granted now, much as Catherine was talking about with antiretrovirals. But this was really groundbreaking work at the time, pivotal to influencing treatment policies and national guidelines and international guidelines for how we manage antiretroviral patients and our HIV-positive patients when they start ARVs and they're high risk of TB. We've also looked at how these epidemics have collided at a community level. So we've already seen that even with a well-run TB control program, DOT strategy alone was not controlling TB in the pre-ART era. And so we, armed with the knowledge that antiretrovirals would reduce the risk of TB in patients, but also with the knowledge that it didn't reduce it all the way back down to the rates in HIV-negative patients, we did wonder what the impact of ART might be at a community level. And we were one of the first to report on the community impact. We showed that with a high coverage of antiretrovirals, the community TB incidence rates were reduced, although this impact was mostly seen among HIV-positive patients and particularly among those who were receiving the antiretrovirals. We also showed that the high coverage of ART reduced the TB prevalence in the community, but again, no significant impact on the HIV-negative population. And so understanding that ART reduced community TB, but really because of its impact among the HIV-positive patients, we wondered what the impact might be on transmission. And so a whole wealth of work has grown out of our interest around understanding TB transmission in our communities. So firstly, we ran a series of tuberculin skin test-based surveys in one of our communities, and we found an extremely high annual risk of TB infection of around 4%, which is the same as annual risk infections in communities before we had treatment for TB. 20% of children who are entering school in this community are already infected with TB, and that risk of infection increases with age, so 70% of them, by the time they leave high school, have TB infection. So that begs the question, where are people getting infected? We have done geospatial analysis of infection and disease, and we showed, as is consistent with literature even pre-HIV, childhood TB disease and infections are associated with the prevalence of an adult TB case on their plots. But this association weakened in adolescence, and so when we did molecular epidemiology studies, they confirmed a very high rate of ongoing transmission in the community, but showed us that less than 10% of adult-to-adult transmission was occurring in the home. So where are adults getting infected? So airborne transmission is really influenced, can be thought through in the framework of social, environmental, and biological factors. So first we looked at the social factors. Where might people be interacting in a way that they may be exposed to TB? And we did this through studying social networks in the community. And we saw I don't know if I got the point right. Okay, so this graphic just shows a largely age-assortative socializing, with most intergenerational mixing happening in the homes. And then, as you would expect, as people got older, from childhood to adolescence to adults, we saw more and more social contacts occurring in their day-to-day life. We also identified that 80% of indoor contacts among adults and adolescents occur basically in 5 locations: households, your own or others, creche and school, work, and transport. And so then we next looked at the environmental factors. So what in these locations might be driving risk for TB transmission? So here, Professor Wood actually collaborated with the engineering department at UCT, and while others have used carbon dioxide concentration monitoring to look at risk for TB transmission, this collaboration developed a portable monitoring device that participants could carry around with them in their day-to-day functions that would continuously monitor the carbon dioxide levels in the spaces they were in. And then when we combined that with social contact data, we could get an estimated daily liters of rebreathed air. Basically, the amount of air you're breathing in that someone else has previously exhaled in that space. So this somewhat alarming approach was a novel surrogate approach to measuring the risk of airborne transmission, because to get a disease that you have in your lungs, you have to breathe it out, and I have to breathe it in. All right. And so we could gather these kind of graphs looking at the environmental factors, the ventilation and ventilation with number of people in a space, to get an assessment of your risk of being exposed of inhaling TB in a given location. And so, armed with this, we went and looked at some of the locations that we'd already identified as possibly high risk. Transport, obviously, was an important one, and we found very high rates of rebreathed air, typically in taxis, less so in trains, but people spend longer in trains with people and potentially with more people in those spaces. And we saw that the poor ventilation, public transport may be a very important, play a very important role in sustaining TB transmission in South African cities. We went to the schools and found some alarmingly high rates of rebreathed air in some of the classrooms, suggesting that these are an important space as well for potential transmission to adolescents. And this work was confirmed. Another technique that we adapted was high-flow air filtration, basically pulling air through filters, sucking air through filters like a very powerful vacuum cleaner, and then testing those filters for TB using a process called ddPCR. And this was a collaboration with scientists at the IDM, in particular Valerie's group and Digby. And so with this technology, we were actually able to show that we could detect TB, airborne genomic TB DNA, in the classrooms in these spaces. So it's not just a theoretical risk based on poor ventilation. If someone has TB in that space, there is TB floating in that classroom. And we've used these techniques to look at other venues like the clinics, shebeens and churches, and there has been modelling work done with, again, with amazing collaborators from around the world to look at how this equates to actual risk of transmission in these communities. So I've talked about social and I've talked about environment, and I'm not going to touch on biological because that is Professor Wood's keynote address later today, and he will surely draw all this together for you. But just to say that this work has clearly identified spaces where future interventions to disrupt transmission can be done, whether that be active case finding, whether it's structural and environmental interventions, simple things as teaching taxi drivers why it's important to keep their windows open, or whether it's air scrubbing techniques like ultraviolet light. So it has given us a solid base to work from in terms of thinking about what next for transmission disruption. So not to steal Robin's thunder, I'm going to just segue a little off from this now and talk a little bit about what we're currently doing and the future work. And I've only got 2 slides to this. I wanted to mention that we have been evaluating biomedical interventions for protecting people from TB. This was a very large phase 3 randomized controlled trial among over 1,600 primary school children in the Klipfontein area. And while we could see that, the vitamin D levels in the active study arm definitely increased by the end of the study, showing that the randomization was held over a study interrupted by COVID and all kinds of things. Unfortunately, it didn't show any protection against acquiring TB infection among these children. We're also very involved in TB vaccine work. We've run a number of vaccine trials with a number of different vaccine products, and currently a few of our sites are actively enrolling in the very large phase 3 study for the M72 product. And we're also involved in the phase 2A for the MTB vac and looking at the phase 2B study coming down the line as well. So just to say that while this talk has in no way represented all the TB work we've done. It couldn't possibly, in the same way this slide is not an exhaustive representation of all the amazing staff, colleagues and collaborators we've worked with over the past 20 years, but it has been a phenomenal joint effort with many, many people to gain the knowledge we've gained and impact policies in the way that we have and hopefully will continue to do. So thank you.
Thank you very much, and I hope, also people will see the power and miracle of medical research is that it really is building on lessons, and so the story grows. So I hope, and thank you, Keren, I think that was beautifully illustrated there. So we're going to now hand over to Flora, who represents I think such important work that also goes on, which is that this organization, the work we do, doesn't only involve scientists or PhDs or clinicians, but very much involves all cadres across the board. And so I've asked Flora to just reflect a little bit on task shifting and task sharing, which I think her organization that she was part of many years ago, Sizophila, really beautifully illustrated. So Flora, over to you.
Sanbonan. I will start by saying that the very first time I heard about adherence was in the year 2000. I think it was in April, where my doctor said, "You need to take these tablets every day." I say every day. I didn't know that some years, after so many years, I'll be standing here. Then I would say I then joined the Sizophila counselors, Sizophila counselors were the people that had heard that you are HIV positive, with different stories. Some were very sick, some were still well. And then I was lucky again that when I was thinking that I was going to die, I was then started on treatment, on research, study drugs. So, Sizophila counselors were people that were living with HIV. Most of us had been started on treatment, so we understood both being tested positive, thinking you're going to die, and what is happening, what does it mean to be HIV positive. So then we were trained as therapeutic counselors. It was, you can understand, not able to pronounce those big terms. And I remember when LGB said it was reverse transcriptase inhibitor. And she reminded me of a teacher. When you go home, repeat this word, reverse transcriptase, reverse transcriptase. So yeah, we're coming from there, and then hence we were called therapeutic counselors. What was a therapeutic counselor? We were people that were going to educate our peers on HIV progression and opportunistic infections and how to treat them. That was going to help us to know when we do home visits, when we visit those homes, we were able to see who else needs treatment. Just by talking, when you get there, and so has had TB of what, you know, oh, not just my client needs treatment here, and you drag that one to the clinic. So what was happening in the clinic as a counselor, when somebody was screened, they get assigned a therapeutic counselor, and then the therapeutic counselor involved will follow that client home. And then you collect all the data there. At the time, we had an SMS, I don't know, to collect the data with, and then you would be able to do all sorts. You will fill the form on that program, and you send it to. I used to think, where are these doctors? Because you would just send it when you are in the field. Okay, fine. So they were week -4 when the very first time the client will come to the clinic. And then when they are week -2, then that's when they were discussed to be started on treatment. So you have been, at that time, you've been collected all the data that is needed, whether they've been to treatment readiness, they've been to what's happening with them. Are they ready to start the treatment or not? Okay. So one was HIV progression that we would tell them about, and opportunistic infections, antiretroviral drugs, and their possible side effects, and nutrition and living positively. These equipped us as counselors to help them, because you could tell when they have side effects or when they have an opportunistic infection. So in the clinic, when they come, we would do pill counts, do counseling all the time. Okay. So in our work at home, it wasn't just that you are a counselor, a police, or what, because when you go home, you go to their places for a home visit. A home visit was either you'll do the pill count, you'll do counseling. Sometimes they will call you to see you, because with some, they can't talk about this with any other person. You are there as the person that they can like discuss anything. You will end up like the member of this family, where even the children will ask you, where is Aunt so-and-so? Why doesn't she come visiting? So, yeah, this work, the Sizophila counselors' work, it didn't end at a point, because it's still there. You're still a Sizophila counselor. Wherever you are, even at home, they will come tell you, I've defaulted treatment and stuff. But I remember one day that I was still in Gugulethu at that time. A couple came with the baby. They had gone to a private doctor, and then they called a doctor in Tygerberg. They really needed a counselor at that time. I gather they called DTHF, and they were sent to Gugulethu. These parents were devastated. Their child was diagnosed with HIV, and they were not HIV positive. They were like mad. And then they were given treatment. But again, that child was put on ABC. ABC was one of the drugs. But because we're not just like counselors, we were taught medication, how to take it and stuff. Having a child that is HIV positive, that is still around. At that time, I had to tell them that the treatment will work and the child will be better. You know, firstly, you are judged. How can they say they don't have HIV? Where did the child get the HIV? But as I journeyed with the family, I think it was now in 2011, when at that time they had known what had happened with their child. The child was breastfed, but by the nanny. And then, yeah. But when they came at that time, the ABC was like the child was to take in the morning only. Then I asked them to go back to the doctor to say, to check that, because it's taken twice daily. It's been helping, my being a Sizophila counselor. It opened my mind so much, and it helped me understand even the meaning of being HIV positive, because I think we become ashamed because we think when they say HIV positive, it's the big thing. But the only thing that is left, that is wrong with somebody, is that their immune system is challenged. The life goes on. I think when we talk about HIV now, after this, the message that still goes on, that nothing is wrong with you, only your immune system is challenged, and you boost your immune system by taking the pills every day. You're still okay. So thanks for the therapeutic counseling. I don't know what LGB thought, but thank you very much, LGB. I think this goes on. People understand that there is nothing wrong with us. Let us live our lives, take our medication, and carry on. Thank you.
Thank you, Flora. Thank you. And I think it was, I wanted to sort of transport you back to 2000, you know, and those early years. Perhaps now, as Flora says, quite glib, a pill a day. You know, we've had young people say to us, it's a pill a day, you know. You want me to take a pill a day to stop having to take a pill a day, you know, around having to take PrEP. But in those days, you know, and Flora's right. You reminded me, Flora, the -4, -2 was because during that month we decided whether that person was actually going to be started on antiretrovirals or not. And there were some people who did not get antiretrovirals simply because we did not have access universally for everyone. And so there was a ration. And so, you know, for those of you who are young and perhaps didn't live through that, I think it's important to just see what has been achieved in 20 years. But I want to say something about the Sizophila counsellors. When we first introduced them, it was 6 or 7 to begin with. They were all folk who had got onto clinical trials and their lives had been saved, and they wanted to pay forward. They too wanted to make sure that other people could take antiretrovirals. Catherine and I, when we introduced the concept to the Hannon Crusade Clinic, to the Googs Clinic, the patients all said, we want to see a doctor. Somebody in a white uniform is the person who should tell us how to take our treatment. We don't want to see peers. That's not okay. But these folk, and Flora's right, we were unapologetic. You needed to know this is a non-nucleoside reverse transcriptase inhibitor. It's not a pink pill. It's not a blue pill. It has a name. Its name is nevirapine. Its name is efavirenz. You've got to know the names because they work differently, they have different side effects, etc. And so we were very staunch, and Flora will remember we even taught PK. It's a 12-hourly dose. It starts here, it goes down there. That's why you've got to take another dose. And these folk, some hadn't done matric, but they got it. They absolutely got it. And they paid that forward. They taught it on. And when we went back a couple of months later, we had a questionnaire to the patients. We said, how was that? The patient said, no, we don't want to see a doctor or a nurse. We want to see these people because they know. They know what they're talking about. And you know, I really want to bring that home because I think this is something that HIV can teach other fields of medicine. TB needs to learn this amazing lesson. I think cancer therapy, diabetic therapy, etc., the value of peers who become content experts and can themselves really help others come along. And so, Flora, to you and the team, and eventually there were 20, 30, 40. The late Paul Farmer had his accompagnateurs we were doing the Sizophila counsellors at about the same time. So we were going down a similar sort of road. But really, this has been the cornerstone of the HIV response for our part of the world. And so just want to pay tribute. It's not just the research. It's also about everything that everybody has done. So thank you for that. Really beautiful testimony. And there's so many stories. I saw some of those photographs. The little, one more anecdote, sorry everyone. The little girl who was about 6, I think she was NY4 or something, and she was being raised by her grandma because both her parents had died of AIDS. And grandma, and in those days, as Catherine said, and even still now, it's a syrup. And Gogo thought every time the child coughed, she must get a teaspoon of cough muti. And so within like a week, all the antiviral syrups were done, because every time the child coughed, and of course, having been born with HIV, coughed a lot, it got another shot of syrup. And so we then thought, got to think of another plan. Gogo can hardly see. You know, she's trying her best. So we got the older brother, and we brought the older brother in, and we got him, or, you know, taught him how to do this. But he had a life of his own. He was an adolescent. And so we were so panic-stricken about how this child was, you know, well, our first child. And just remind everyone, children were looked after at Red Cross Children's Hospital. It was only many years later that they started to get decentralized. And here were these adult physicians now having to take care of these, you know, precious children. And this wasn't working. And then at some point, we sat this child down, who was 7 years old, and it became clear she was quite capable of taking her own medication. And so so it was a wonderful lesson for us. And she was brilliant at taking her own medication. I saw her in the photograph, it reminded me of her. And she did very, very well taking her own medication at the end of the day. So there was another lesson about, you know, patient resilience and what people can do. So we have all been learning all the way along. So you have earned a tea break, everyone, before I really get stuck into the anecdotes. And so please do go and have your tea break. We are only allowing you 15 minutes. And if you can just be back sharply, because there is another whole potpourri. We're going to move into adolescence, into prevention, and many great stories are still ahead. So thanks everyone for your attention.